thank you very much for the nice introduction. So now I have the pin of the HPB Turkish Society, so I have to pay my dues while I'm leaving, don't worry, as a member of the society. It's true, I mean, you're definitely all invited to the next EHPBA conference, and I really think that there is a great value in having, you know, the HPB Turkish Society within the frame of the European and African HPB Society. And I talk here in the name also of Marchegiani, who gave a virtual presentation here at this same conference. So the second talk today, now we completely change our area, our topic, but it's probably one of the, I would say, my favorite one. And you see here that in these funny pictures we have, see a very famous shining character acting like a killer to a benign and scared cirrhosis adenoma. So it's a funny way to picture that sometimes as surgeons we could be a little bit too invasive, a little bit too aggressive within this entity that in most of the cases are not or might be not surgical candidates. But of course, as for the previous presentation, we know it only because now we have evidence supporting this. Otherwise, of course, from entities that we don't know what the biology is about, we could be actually detrimental with our surgical attitude. So in this next 20 minutes or so, we'll try to go through this entity and what is the current standards for surgical resection about cystic neoplasm of the pancreas. So the first key point, and if you have to remember one thing about pancreatic cystic neoplasm, is this slide. So probably after this slide you can all leave and enjoy the, you know, the Sunday in Antalya, which is, the take-home message is, we deal with a very frequent issue. So most of the books reporting that these are infrequent lesions are wrong, because cystic pancreatic neoplasm are extremely common in the general population. That's the very first and probably the key message of the entire presentation. The more we find cysts in the pancreas, you see the red box there, the smaller they are. Why? Because now we do CT scan, we do MRI for a lot of purposes other than pancreatic reason, and we incidentally find small and asymptomatic cysts in the pancreas. We don't know what they are about. And then what happens? Well, it happens a history of panic, I would say, for the patient, a history of, I don't know what to do, maybe I have cancer. The patient they went on Google, you know, and they think that they will die anytime soon. So this is a very relevant problem that we face as a pancreatic community right now. This paper just came out 1 week ago. It comes from my friends at the Mayo Clinic in the US, and you see that there is a trend in the diagnosis of pancreatic cystic neoplasm increasing with age. And you see in the box out there that the true prevalence can be as high as 20%. So can you easily calculate how many millions of Turkish people will suffer for this? You know, Turkey is a huge country, so imagine the numbers we're talking about and how relevant this condition is. Because whenever we face a cyst in the pancreas, we have many factors to keep into consideration. The first ones is that in front of you, you have an asymptomatic patient with probably a very bad psychological burden because of this disease. And what you see is actually, you don't know what it's about because the biology is not known. And on the other hand, even if you are the most skilled pancreatic surgeon in the world, you know, and you have to remember that surgery still is burdened by relevant morbidity, mortality. We know that we have the issue of diabetes, for example, but also to follow up all these tiny little cysts. Even if you are lucky and you have the best gastroenterology in Turkey, is actually very difficult and it has a lot of cost. So we even have this problem of follow-up of thousands and thousands of cysts every 6 months and every year. So what to do with these patients? We start from this, which is the WHO classification of the cyst. So it's actually look pretty easy. So some of them are completely benign. On the other side of the spectrum, some of them are truly malignant. So easily no surgery, yes surgery. But then we have this gray area of pre-malignant, which means they can become malignant at some point, namely most of IPMN. You're gonna hear a lot about IPMN in the next 10-20 minutes. And those are truly the, I would say, most tricky dilemma that we face every year. And on the other hand, you have this. What you look, so your decision will be made on a drop of water, on what you see in the fluid within the cyst. So it seems very difficult actually to depict what the biology is starting from a drop of fluid, which is actually what you get when you feel this cyst, this entity. Sometimes it's easy. For example, look at the first picture here. A huge mass invading basically all the belly of the patient with some calcification inside. I would say I would think about serosustrenoma. This is not very difficult. Second case, young woman, body tail of the pancreas, tiny septation here. Well, I would probably think about a mucinous cystic neoplasm. Not so difficult. And finally, you have an either solid and cystic neoplasm in a young lady, 16 years old. Well, I would probably always think about a solid cerebropapillary tumor. So whenever this is the case, you would say, hey, Giovanni, it's not so difficult for cystic neoplasm. But what if I tell you that the 99% of the cyst, they will all look like this? Totally non-specific holes in the pancreas, you see, without any feature. They don't look as anything, as I showed you before. So those are the true problem that we have to face. And I found this very nice cartoon. I posted it on Twitter a couple of days ago, because we now started to develop ways to define which cyst is what, because according to some epidemiological factors and the biology of this cyst, we are now be able to define that there are very different features about this cyst. So we're going to start with the good guy, the serous cystadenoma. So this is typical, I would say, of the 5th, 6th, and 2nd decade. And if you have to remember one thing about the serous is that it is a benign condition. So the evolution, the potential of malignancy here is zero, okay? In the back, we used to have carcinoma, serous, those are like, forget about it, they're bullshit, don't exist, okay? Serous is a benign entity. Still, the problem is that most of the time, it comes with atypical presentation. So it's very similar to mucinous counterparts. So we don't know we're dealing with a serous cystadenoma. That's the problem. This was the biggest study performed 10 years ago. This is like a super big database at the time, and this was for the first time the definition that serous cystadenoma is only a benign entity. And the problem is the mortality when we operate on a benign tumor. So here the surgeon is the danger for the patient in this case. So I tried to emulate this concept on a recent paper in Annals of Surgery, and you see that even now, even in high volume centers in Italy, we still do resection for serous cystadenoma. You see, it's this yellow box. So less than in the past, but still we operate on serous cystadenoma. Why? Because whenever we found this cyst in younger individuals and in the body tail of the lesion, we are wrong in 20% of the cases. So we go for surgery for something we thought it was a mucinous, but indeed it came out being a serous, and those are our mistakes. So we have to do our best to define whether this is a serous adenoma. We want to ask our endoscopist to put a needle inside and to check which fluid is in the cyst, because those resections, if the patient is asymptomatic and the cyst is small, are wrong resection. And this is very important, I would say. So, to the question, when is indicated surgery? Only whenever you have big serous adenoma causing symptoms, true symptoms, obstructive jaundice, acute pancreatitis. Beware of the patient complaining of non-specific pain in the belly. This is not the serous adenoma, right? Check for gastritis, check for colitis. The true symptoms are only jaundice and acute pancreatitis. But of course, whenever you have no symptoms, those patients you can forget about bringing them to surgery. So we go back now to the family of cystic neoplasm, and now we face to, let's say, the other side of the spectrum. We're facing now the malignant entity, solid cerebropapillary, the so-called daughter tumor. So this is a tumor of the younger adults, pediatric population. Most of them are now found incidentally in very young kids. So imagine all the implications for the family, for the patient himself or herself, because by definition, these are malignant entities. So it's not pancreatic adenocarcinoma, but still this is a low malignant potential tumor. It can be even metastatic at diagnosis in 10 to 15% of the cases. So what do? Here we are very aggressive. Here we need surgery. When? Every time. Okay? So even when the patient is metastatic, you always want to go for a debulking. This is really a tumor in which we as surgeon can play a major role by doing a resection in the pancreas and even in the mets if they're present. What happens if we analyze the specimen? Well, there are factors that predicts the likelihood of having a recurrence. So you want to ask your pathologist, and let me tell you, some of the best pancreatic pathologists are Turkish. I'm not gonna name them, but most of my pathologist friends are Turkish, so you have a very big tradition in pancreas pathology. Some of them, they work in the US, but some others, they came back to Turkey. And this is what my fellow pathologists taught me. Look for these predictors, because the risk of having a recurrence is not zero. And this is something that you want to find out based on the analysis of your specimen, and think about the implication for a pediatric patient in this case. So that's a very relevant possibility. So we always want to go for surgery in case of solid cerebropapillary tumor, and possibly we never will observe this. So as much as I'm cautious for serous adenoma, at the same time I'm very aggressive whenever I face solid cerebropapillary tumors. And now we start digging into the big thing, okay? So the mucinous neoplasm. Those are the most important and also difficult lesions to deal with. So we're gonna start with mucinous cystic neoplasm. You see here we have a female pancreas, a mother tumor holding a baby. Why? Because in this case, in case of the MCN, there is a role of pregnancy in enhancing these tumors, because they show a mucin-producing epithelia supported by an ovarian-type stroma. So the possibility here is that whenever we are in the embryo, some of the cells pertaining to the ovaries, they leave some seeds in the tail of the pancreas, and they eventually become mucinous cystic neoplasm. That's why, and again, this was a lesson from my pathologist in Italy, so they are always in the body tail of the pancreas, and in 99% of the cases they occur in young females. So again, imagine the implication of a diagnosis of a mucinous cystic neoplasm. So what to do? Whenever there is, I call it meat, so whenever you have meat inside, you have to worry. Because if you have invasive component, it's there. It's in the meat growing inside the cyst. So beware of solid component in these cases. If we look at the guidelines, what to do with mucinous cystic neoplasm, again, there seems to be no doubt. Mucinous cystic neoplasm are always a surgical candidate. But is it true? or possibly those guidelines are a little bit, let's say, old and need to be updated. Should we really do surgery every time, no matter what? So this was a paper we published a couple of years ago on the British, and you see that if you follow up some of the mucinocystic neoplasm, not all of them should be operated. Because if you have mucinocystic neoplasm smaller than 5 centimeters, without the meat I showed you, so without mural nodules, then the risk of cancer is almost zero. Zero. So should we do surgery in these cases? Let's talk about it. Let's take a break. What to do if we face a young 30-something years old lady who wants to have a baby? Should we take the pancreas out before the pregnancy? Probably not a good idea, right? So, again, let's take time for the resection and remember that we should go for surgery whenever you have symptom or whenever the tumor is more than 5 centimeters or the CA 90.9 is high and there is this solid component. But if those features are absent, you can start surveillance in these patients. And I myself do surveillance on several dozens of these mucinocystic neoplasm without any problem of these people. So keep this in mind and avoid being too aggressive, because probably in the past we've been too aggressive because these lesions are suitable for example, laparoscopic or now robotic distal pancreatectomy. So probably we were a little bit too aggressive as surgeons in this regard. So, if it was easy so far, now it becomes very difficult. So, last 10 minutes of your attention and then the conference is done for the most, I would say, interesting part, which is IPMN, the dilemma of our modern times. So, let's try to make things a little bit easy. So, when I was in the US 10 years ago, unfortunately, I did this study on IPMN of the main pancreatic duct. And there is no doubt that whenever the IPMN is in the main pancreatic duct, this is a candidate for surgery, because the risk of malignancy is actually high. So if you reach a diagnosis of main duct IPMN, you have an indication for surgery. Easy, right? Not so easy, because there are in many cases, once again, a mistake in the diagnosis. Because when I came back to Europe, I did this other study, and you see that if you consider just the dilatation of the duct as a predictor of cancer, you might be mistaken, because in some cases we think it's a main duct IPMN, but indeed it's not. Beware of chronic pancreatitis. Beware of ectasia of the duct. Particularly when the duct is only 5 millimeters, 6 millimeters, be careful. So once again, if you reach the diagnosis of main duct IPMN, you have a surgical candidate. But main pancreatic duct dilation alone does not mean necessarily main duct IPMN. We have to be very careful in providing this message. So this was for IPMN of the main pancreatic duct. I cut it to 3 slides, okay? But for brain duct IPMN, it's impossible because it's a very, I would say, difficult dilemma to dig, because now we have evidence that contrarily, completely in contrast with main duct IPMN, here the risk of malignancy is very low. It's actually lower than the risk of mortality for a pancreas resection. So if we operate all BD-IPMN, we will kill more people because of the surgery than the cancer that we're going to take out. So we have a very big problem here. So Houston or Antalya, we have a problem here. So what do the guidelines say? Unfortunately, we have many guidelines. Sometimes it's not easy to dig into the guidelines. I am guilty myself because I am part of 2 out of 3 of the international guidelines. So there are some indications for surgery, and those indications are pretty straightforward. So whenever you have these features, You can call them high-risk stigmata, you can call them absolute indication for surgery, but once these are present, you have a surgical indication. The most important one being mural nodules. Mural nodules is how we call the invasive type or the high-grade dysplasia that grows within the branch duct IPMN. So this one I found is really bad, you see? It looks like a skull. It's terrible. Most of the cases are not like this, but you really want to be sure that are true mural nodules. And here, differential diagnosis is with mucin plugs, because you know you have mucin inside the cyst. So you really want to ask your endoscopist, please check with contrast enhanced endoscopic ultrasound whether this is a true mural nodule or it's a mucin plug. Okay, because they can look similarly at CT scan or MRI. But the biggest problem is not when a mural nodule is there, because if a mural nodule is there, you have indication for surgery, is whenever you have these worrisome features or relative indication for surgery. What does it mean? We don't know, honestly. Those are the very difficult cases because there is even not reliability in the guidelines. So the guidelines are conflicting. Some of them say surgery, others say observation, others say endoscopic ultrasound. So this becomes very, very confusing and very, very difficult. Because please keep in mind that guidelines in most of the cases are just expert opinion. Because we don't have any evidence on that. So beware, be cautious on the use of the guidelines, even those I am co-author. Please forget about that. So what do we have to do is once again thinking about the patient, thinking about the single case we are facing. Always evaluate, please, the clinical features. Who are we watching at? Is the cyst in a healthy 60 years old person, or are we talking about an 85 years old grandmother in bed after 3 heart attacks? Do we really care about the cyst? So it seems obvious, but it's not. So always think about the clinical feature of this patient. What is the patient's will? Some of the patients are very anxious about their cyst. They come to you and say, please doctor, operate on me. I want my cyst out. Others are very reluctant. They say, oh, no way, you're not going to touch me. So you have to keep this in mind as well. It's another factor. And so only in this way, you will finally have what I call a tailored approach. So it's really shaped like a dress on the specific patient you are dealing with. And at the end, it comes with this, which seems to be confusing, but it's not. And it depends whether this is the first observation of the patient, you have it here, or if you are within surveillance, which means here. So whenever you have these features, so the patient is jaundiced, solid component, true mural nodules, so vascularized, or the duct is more than 1 centimeter, you have a surgical candidate. And not only if this is first observation, also if during the follow-up the patient develops these features. That's why it's important to follow up this patient. Whilst if you have these relative indications, so you have features that are in between, now we have a very important tool, which is contrast-enhanced endoscopic ultrasound, possibly with biopsy, either FNA or FNB. But my advice, whenever you go for endoscopic ultrasound as a surgeon, you need to have a question for your endoscopist. So the endoscopist needs to have a question to be answered. Why you do endoscopic ultrasound? Not because you are confused. You need to have a specific question. I have a mural nodule, tell me if it's a mural nodule or a mucin plug. So that's my advice. Always come with a question to your endoscopist. Otherwise, it's just a waste of money, it's just a waste of time. Okay? But again, in most of the cases, 99% of the cysts will have this, no indication. And then you start surveillance, which means you start a long journey with your patient to define whether the cyst is changing or not. So the take-home message here, is when you see a cyst, don't judge it from a single picture, but you would rather wait and adding picture to picture, like a movie, judge it dynamically. Because in this way you will have insights about the natural history of this cyst. And if you do that, look what you can find. So this is a paper we published in JAMA Surgery 2 years ago. And here we added the value of surgical series. So all those patients were resected. So we had final pathology. But all of them, they were observed before surgery. So think about that. Those are the most important patients that you have. You did observation, something changed, and then you went for surgery. Okay? So that's why we call them crossover. So because they crossed from observation to surgery. And in the end, we came out with this traffic light from green to yellow to red, where you see that the, I would say, most dangerous situation is not whether they have this worrisome feature or high-risk stigmata and they are stable. The most dangerous condition is when the patient goes from null, so from nothing, to high-risk stigmata, or from worrisome feature to high-risk stigmata, which means this cyst is changing over time. This is the most important factor. So, once again, whenever you see a patient with a cyst, take your time, study the situation, and if nothing is happening, then you can label this patient at low risk. But if something is happening, then you really need to be very proactive and ready to go for surgery. That's the very, very important rule about IPMN. So at the end, you will come out with this, which is what I call the picture-to-movie approach to IPMN. We start from up here. We have a patient, and this drop is the cyst, okay? And at the beginning, you only have a picture, right? Because you have only one observation. So, of course, you always want to consider how is the patient, whenever there are comorbidities, what is the risk of surgery in this patient? Once again, the same policy does not apply to a 50 years old or to a 90 years old patient, okay? And then you start. What about the features? Do we have indication for surgery, or do we have criteria for endoscopic ultrasound? If the answer is yes, then go for surgery or endoscopic ultrasound. But 99% of the patient will start observation at this point with MRI or CT scan, depending on your centers, every 6 months and every year. And then you start watching the movie. Picture after picture after picture. You see this person is growing, yeah? Building a family, getting old, you see? So this is true, because that's what we do with our patient. We follow them up year after year. And every time, the question is the same, which is this: is the lesion stable? Yes or no? If your answer is yes, then you are good to go to the next follow-up. But whenever the answer is no, then you go back and you ask yourself whether there are criteria for US or for surgery. That's what we need to do at every follow-up, to the point that the new question becomes, is there going to be an end of this follow-up? Because that's now the big question. So this evidence, which is the topic of this talk, is now, I would say, pretty solid. What we don't know is about the end of the follow-up. Because the problem is that now we have, as I said, thousands and thousands of cysts under surveillance, and this is becoming not sustainable for our healthcare system. So probably in the next talk we're going to focus on the follow-up, because that's another, I would say, very important matters on the management of IPMN. But for the management of surgery, once again, the crucial question you have to ask is always this: whether the cyst is stable or not. Because if your answer is yes, then you keep following your patient, you reassure your patient, you tell this patient you don't have cancer. We keep watching you, we keep observing you. So the take-home messages regarding the different cysts are that for serous adenoma, we basically never go for surgery, only when the cyst is very big and you have true symptoms related to the cyst. We always go for surgery whenever you deal solid cerebropapillary tumor, always. In the past, we were also very aggressive with mucinous cystadenoma, but I told you, if the mucinous cystadenoma is small and has no mural nodule, you can put this patient into follow-up. Don't rush. Don't rush. You have, of course, a surgical candidate for main duct IPMN, but be careful that a main duct dilatation does not equal a main duct IPMN. So once again, take your time for a good diagnosis. And finally, branch duct IPMN, I would say 99% are not and will never be candidate for surgery, but you have to be ready in very selected cases to be aggressive only when you have signs of degeneration in this cyst. So once again, for those who were not here before, I'm warmly welcoming you to Padova, which is, again, the place where the Wirsung duct was found by the German anatomist, and so we call it the home of Wirsung, where we stand as an HPB and, for my part, a pancreatic center. But for all the young and active HPB trainee that I see, this is the event you want to attend. So I am the chair of the membership committee of the EHPBA, and in 2025 we will gather in Dublin. We need and we want as many Turkish trainee and HPB surgeons. So please consider to start your science now to be ready for the abstract proposals for the EHPBA conference in Dublin. And with this, I am done. Thank you very much for the honor of the podium, and I'll be ready to ask for some questions. Thank you.
Thank you Giovanni. Soru var mı? Buyurun, mikrofonu alalım lütfen size.
Thank you for excellent presentation. My question is about do you think IPMN is a tumor marker?
I like your question, but I want to understand it. So thank you for that. What do you mean with is a tumor marker?
I mean that how do you follow your patients operated because of the IPMN following up procedure?
Okay. So the question here is whether having an IPMN is a risk factor for developing an additional pancreatic cancer. And the answer that comes from the genomics is yes. So those are, it's called field effect. So there are, again, a higher likelihood of developing other IPMN or even pancreatic cancer, which is something you should be very afraid of. And it's also the reason why you don't have to be very aggressive with branch duct IPMN, because even after surgery, you have to keep surveilling this patient, okay? So the question about the follow-up depends on the pathology of the IPMN you took out with surgery. So if the IPMN was already cancer, then the same policy as for pancreatic ductal adenocarcinoma applies. So you start with a 3 months, then 6 month basis follow-up, not just with a CT scan or MRI, but also with lab tests. You want to check the serum marker, CA90.9, CE8, and of course the clinical evaluation. But if the IPMN you took out was low grade or high grade, then we know that by definition the risk of recurrence is 0, but you have a risk of developing a new IPMN or a new pancreatic cancer. So you might speculate, oh, should we do then for total pancreatectomy? No, there is no evidence that you should do that, but every patient developing an IPMN eventually being submitted to surgery needs to be followed up for the rest of his or her life until this person is a surgical candidate. So that's very important as a concept. So to answer also to your question, should we follow up every IPMN? If the patient is not a surgical candidate, the answer is no. because then it's just a waste of money. Okay? But thank you for the question, because yes, IPMN are a surrogate marker of a potential field defect of the pancreas. We still don't know much about genomics, but I am sure in the next future there will be a test defining the exact mutations taking a role in this carcinogenesis. But still we are very far away from there.
Thank you.
Professor Schöning.
Giovanni, thank you very much for this wonderful talk. Really appreciate it. I have a question concerning rare cases. Imagine you have a middle-aged woman and she develops something like rheuma and she needs immunosuppressant. So she has a branch duct IPMN. What would you suggest? Like prophylactic enucleation or?
Thank you very much for this question that really highlights your expertise in HPB because I usually have this discussion with my liver guys and my liver transplantation team. So this case is actually very relevant because I told you that in Padova we do a lot of liver transplantation and all these patients are immunodepressed by definition. So the message is, so far, no evidence that there is a detrimental effect on the natural history of IPMN because of immunosuppression, but no very solid data. So, and I'm happy to spoil you this, I am now supporting an European study on liver transplantation patients with cyst to see the natural history, because my hypothesis is that there might be an effect on their growing. But to answer to your question, so right now I wouldn't be more aggressive, for example with enucleation. Don't make me wrong, I love enucleation, but I usually do it for small neuroendocrine producing, for example, hormones or insulin. I don't trust that much enucleation on IPMN, because if I have an indication for surgery, then I want to do an oncological resection. I want to have a lymph node harvesting, I want to do an oncological resection. Also because enucleation for the pancreas can be tricky. I am a fan of them, as I said, but I mean, be aware that in most of the cases you can have fistula, you can have complications, so I am not that aggressive in this case, but I want to have more data regarding the natural history before being, let's say, more reassuring regarding this case. So far, I would put your patient or this patient, this middle-aged woman, into a strict follow-up.
Thank you very much.
Thank you.
So, Giovanni, you emphasized that for evaluation of the cystic lesions, CA99. I want to just make clear for this, should be just serum CA99, right? Because some gastroenterologists using to the aspiration fluid, it is correct or not? We use to the just carcinoembryonic antigen for fluid exam. You emphasize that 99 is important for serum, right? Not blood, not aspiration fluid.
No, Mustafa, great question, Professor Kerem. So let me make this point more clear because you're absolutely right. So CEA is great as a test in the cyst fluid because it tells you whether the cyst is mucinous or serous. So it's very important test in the cyst. Now we also use glucose levels, same accuracy as CAA, doesn't matter, let your endoscopist decide. At the end your question remains the same. Is it serous or mucinous? So once again we go back to the concept, always ask your endoscopist a question, otherwise the examination is useless. But CA90.9 becomes more relevant in the serum whenever you have the risk of a cyst to evolve. But please do not rely only on CA90.9. So there is a paper from the Netherlands that I just accepted on gastroenterologists where they did a lot of unnecessary surgery because the CA90.9 was high and the cyst had no feature of malignancy. Please remember that CA90.9 is not specific. It can be elevated also in other type of cancers or because patients is expressing this protein too much. So always make the pieces of the puzzle coming together. because ideally CA9.9 is a marker of advanced tumors. We all use it, for example, in pancreatic cancer after resection with our friends oncologists to define whether you have a relapse or not. So again, it's not the perfect marker, but it's what we have. So right now we have to do the best with what we have.
Başka sorumuz yoksa oturumu kapatmak istiyoruz. İki şey, bir Profesör Giovanni Marchegiani'ye bir hatıra olarak bir başkanımız Mustafa Kerem plaket verecek. İki, bundan hemen sonra beraber bir fotoğraf çektirmek için sizleri de sahneye davet edeceğiz. Giovanni, two things. We would like to give you a small reminder of the Congress, so please stay on the stage. Professor Kerem will present you the small gift, memory. And then we would like to make a picture all together at the closure of this beautiful Congress. Herkese teşekkürler. Thank you very much.
Thank you.